Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Ash Mandavia. He's a healthcare executive. Today's Kevin MD article is Why U.S. Healthcare Pricing is So Confusing and How to Fix It. Ash, welcome to the show.
Thanks very much, Kevin. Nice to meet you. I'm Ash, a medical doctor by background, trainee psychiatrist over in the national healthcare system in the UK before moving into health tech about 10 years ago. Started up in a startup environment, really focusing in on some of the hot topics at the time, particularly substance use disorder. And I joined a company called Quick Genius, they're now known as Pelago, Series C health tech startup, focusing in on their commercial growth across the EMEA region and thereafter the US, and really kind of came across a lot of the pain points around revenue cycle management for healthcare organizations over in the US. And that is exactly what led me to co-found a company called Soha Health, which is my company that focuses in on trying to automate a lot of the clinical operations around determining insurance eligibility for patients coming into a clinic.
You talk about some of the pain points in U.S. healthcare. Pricing is, of course, one of them. And you talk about that in your Kevin MD article, why U.S. healthcare pricing is so confusing. Now, for those who didn't get a chance to read your article, just tell us what it's about.
Yeah, in this article, I really touch upon some of the opacities in pricing within the US healthcare system. I often make the analogy that, and this is as being a kind of naive European person kind of looking in with a fishbowl lens into the US healthcare system, but I often make the analogy that you could turn up at a gas station, think that it's going to be $1 per gallon, and by the end of filling your tank, it could be $100 per gallon. And that idea is alien to a lot of us over here on this side of the pond, but also in a consumer environment. If you were going to Amazon, for example, to the checkout, you don't expect your pricing to completely change. But that often happens in the healthcare system, and often the reasons for that around a lot of opacity between the payers, the healthcare insurers, and the healthcare organizations themselves, the way in which pricing is set up, which tends to be per on a volume basis, so pricing per service offered, as opposed to kind of more value-based pricing models. And a lot of folks don't seem to have the real kind of basic literacy in health insurance vernacular. So understanding what copay, co-insurance, and deductible may mean. And don't get me wrong, I'm 3.5 years into this journey, and I still find those terms to be confusing, particularly with certain plans, certain payers. But without kind of addressing a lot of these issues, it becomes really difficult for a patient to navigate the system and often results in a barrier to access to care.
And even myself as a physician in the US healthcare system, if a patient asks me how much a diagnostic test would
Yep.
cost, I cannot give them a straight answer because the answer is it would depend on so many different variables, like what kind of insurance they have, for
Yep.
instance, and the payments that the hospital system would receive from each insurer. It would be different. So I could imagine how frustrating that is to patients. And just given your perspective, of course, being overseas, this system that we have in the United States, this is almost unique in the world, right?
Right. Yeah, absolutely. I mean, here over in Europe, we're quite used to more kind of uniform payer systems. You have one healthcare system that manages care for everyone, and you typically pay into that system through your national insurance, and that ultimately results in high expectations on care delivery, but also less folks being able to kind of slip through the cracks. So the social system kind of is there to be able to kind of pick those who are kind of most at risk and have least equality in terms of access to care. So yes, it is very, very unique in the US healthcare system, but that's also where a lot of investment can take place, a lot of research can happen, a lot of cutting edge care can be delivered. I still love the idea that a lot of our customers who are behavioral health providers who work on a kind of national scale can get a patient who comes onto their website and have them in an appointment within around 30 minutes. And that's still very, very unique compared to accessing care here in Europe. So I certainly think that there are pros and cons to the system, but certainly this area ends up resulting in a lot of confusion, uncertainty, and ultimately, I think patients tend to question whether they should be attending for care. And that, for me, is the worrying element because ultimately The less you attend seeing your primary care physician or perhaps like a behavioral health physician, the more problems worsen, right? And then we have to spend even more money to try and fix the issues as they kind of express themselves.
So before talking about some of the paths forward and the solutions, just give us more granular detail on the impacts patients are seeing. You wrote in your article that 18% of adults faced a surprise medical bill of over $1,000 in the past year. So give us the types of scenarios that these patients find themselves in that would give them a surprise bill.
Yeah.
Tell us about how common or uncommon or how routine or non-routine the types of treatments and visits that they would have to go to get these surprise bills.
Yeah. Yeah, there's multiple ways in which that can then end up happening. So if an eligibility check wasn't carried out at the beginning when the patient tried to access care, so their insurance information perhaps wasn't correct on file, or they didn't have their insurance information to hand, the provider organization was too kind of inundated with requests at the time, so just decided that if that patient said that they were with Aetna, they were going to take that on face value and see that patient through. Ultimately, what that ends up with is, okay, maybe the patient did have an Aetna plan, but actually they weren't eligible for this sort of care. Number two, it could be that actually we're eligible, but that patient's plan in particular was out of network with that provider organization or with the individual practitioner about to give care, in which case they would be deemed out of network. If they were charged in network rates or that claim was processed as being in network, that patient would end up with a surprise bill. And the worst, and I think the most challenging that is one of the kind of key reasons why my company Sohar exists is around changes to insurance that take place. Often people think that insurance is static; it stays the same throughout the year, may only change just in January when you get January resets, but it's not quite the case. A lot of variables play into it. So your deductible is constantly changing depending on how much care you're accessing. It's very hard to be able to look that up and see that in kind of real time. And what we see, particularly in the behavioral health space, is the issue and prevalence of carve outs of payers. So, not every payer or plan will have enough providers, particularly mental health practitioners, in their network, in which case they contract out to a third party. And if your provider organization is not in network with that third party, then they're actually out of network. And it's very hard to determine this. And so we do a lot of work in our technology in order to be able to kind of pick that information up, that subtle nuance. But often some of the customers that we have and have spoken to are running off tens of millions of dollars of claims in order to not end up delivering a surprise bill to their patients. But of course, not every organization has that luxury. In the end, they'll probably end up having to come to the patient to ask for that money. And ultimately, it's an administrative error on their side. And the patient, unfortunately, kind of gets the brunt of that. They could go maybe 6 sessions without finding out that actually they're not in network and therefore they have to pay out of network rates. And that's a real travesty. And it results in mistrust in the system.
And that mistrust, as you said earlier, can lead patients not to seek out care when they really need it.
Yeah, yeah, exactly. So, I mean, there are pathways forward, and we certainly think that technology can help in this space. As you can imagine, like every other industry that we've seen, particularly, I kind of alluded to online retail before, but in other spaces as well, particularly in the banking industry, more consumer-like experiences exist.
Yeah.
Things are faster, happen quicker, involve less administration. And yes, there's a huge amount of opacity that exists there in terms of data exchange between payer organizations and provider organizations, but there are digital tools that can make life easier. And so a tooling example for that is tooling like ours, in that we cut down a process that can take an administrator between 20 minutes and 2 hours to kind of figure out, and we cut that down to 20 seconds to work out, is that patient eligible? If so, are they in network? And if so, what is their obligation to pay upfront? And as we kind of shift the dialogue to not expecting a surprise bill to come later on, but actually saying, no, we're pretty confident that it's going to cost you this much. Please proceed to take the to provide a payment, and then we will see how the adjudication goes later down the line. But to have confidence, like to around 95, 97%, that actually that number that was quoted to the patient is actually going to be the number, leads to a lot less attrition, a lot more trust, a lot more credibility. But also, it's good from a cash flow perspective. You know, providers typically have to wait 2 to 3 months to get paid. That's
Yeah.
really difficult, especially if there's a big cyber outage that knocks out one of the big kind of clearinghouses, one of like the
Yep.
intermediaries between the provider organizations and payer organizations, so that they can't get paid. So anything that can be done to kind of mitigate that, I certainly think is beneficial. And it kind of leads me on to like the other point that I alluded to in the article, which is like both provider organizations, whether that's hospital settings and clinics, as well as the insurance companies, kind of have an obligation, a responsibility to try and exchange data in using better mechanisms. And we are now starting to see this. So there are new kind of like CMS regulations around prior
Hmm.
authorization. And I think eventually it will come to our space around eligibility determination, network status determination. Still a long way to go there, but trying to bring down those barriers and create more transparency between those organizations and having to kind of have that dialogue between both parties will ultimately, hopefully, involve a stop kind of costs from spiraling out of control. And lastly, it's accountability as well. Like there are very little kind of penalizations or measures taken in place for non-compliance with delivering transparent pricing in care delivery. And so often what we're finding is that provider organizations say that they want to be transparent with their pricing, but either they don't have the technology to help them do that at a scalable way, or they kind of don't do it and then risk any sort of like repercussions. But if there aren't that many repercussions, then they're going to continue to operate in that way. So it really kind of balances in on both sides that act in the best interest of the patient.
In your article, you talk about patients' healthcare literacy needing to be improved to help with this transparency. So, what are some pathway forward from that transparency standpoint from the patient perspective?
Yeah, that's a very good question. I think I came across a statistic when I was first kind of researching the area, which was that only 4% of Americans, and this doesn't go up much when we kind of look at even physician population, are aware of what the copay, co-insurance,
Yeah.
and deductible actually mean, you know, which plan they're actually part of based on their health insurance card. I think awareness is really important, very, very important to kind of know, understand what your insurance actually means. Second, I think there's an obligation on providers to actually provide explanations around the numbers that they're presenting and not just assuming that the patient will understand.
Hmm.
And then thirdly, there has to be better ways for the patient to be able to check, monitor, see these things happening. And I do see change taking place in the industry around this. The existence of AI chatbots, voice AI agents may be daunting and actually frustrating at times. Yes, they're not perfect, they're not great yet, but at some point they are going to be able to take the time to explain what these different values mean on the phone when someone dials in to get an appointment. And I think that's going to be a very crucial element to kind of leveling the playing field, allowing patients to understand more about what to expect.
Now, it sounds like we've been talking about transparency for years now. So, what makes your approach different, and why do you think that it would work this time?
Yeah, absolutely. I think the element here is that there's kind of two ways to think about pricing transparency. Having transparency such that you can say that generally speaking, these diagnostic tests or these sorts of interventions are going to cost X amount, or having transparency to say that hospitals in this region typically charge or are contracted for this rate for this type of service. Let's say it's a physical therapy service or an MRI scan, to then level the playing field between the provider organization and the payer. However, we don't really operate so much there. It's really around the kind of interaction between the provider and the patient where our technology operates. So the data that we surface up in seconds, in real time, allows the provider to say, okay, this individual is eligible, this patient is in network, and this patient is therefore going to, based on our contracted rates, going to be charged this amount. And when you get to that level of confidence with the data coming back, which notoriously has been quite sporadic, not so accurate, then you can actually deliver that information directly to the patient. Where we do things differently, of course, we try and use kind of cutting edge technology there. So we use AI in the form of machine learning and LLMs to be able to pick out the most accurate data possible that comes back from a payer organization. When we make one of these kind of digital fax requests on behalf of this patient, we use a lot of routing and knowledge, industry knowledge about how the payers tend to operate to be able to kind of maintain and keep that up to date because it's ever evolving, ever changing.
We're talking to Ash Mandavia. He is a healthcare executive, and today's Kevin MD article is Why U.S. Healthcare Pricing is So Confusing and How to Fix It. Ash, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Yeah, absolutely. I think definitely for on behalf of the audience, if you're in a position where you're working in a provider organization, I think certainly one of the areas that tends to be overlooked is around kind of clinical administration. Doing the administration work, kind of trying to align the clinical administration workflows and trying to keep up with all the changes taking place in that space. And ultimately, I think often there is a lot of fear around the use of technology, whether that's from an information security or cybersecurity perspective, whether there's worries about the budget spiraling out of control. But I would say that my key take home is that actually technology now does exist there that's relatively affordable, can empower clinical administrators and operations teams to be able to do the work that they used to do in hours, in minutes, or in seconds, and ultimately can result in much better patient kind of satisfaction with their experience of accessing care. So, yeah, my key takeaway message is that technology is here to help, and don't be afraid of using it in this setting.
Ash, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you.